Hi, everybody. It's Adam with HeartValveSurgery.com. We're here at the Heart Valve Summit in Chicago, Illinois, and we're on Facebook Live, and I'm thrilled to be here with Dr. Patrick McCarthy. Dr. McCarthy, thanks for being with me.
Thanks, Adam. Always good to see you.
Yeah, and just so everybody out there knows, his team has been tremendous supporters of HeartValveSurgery.com, and he is the Chief of Cardiac Surgery at Northwestern Memorial Hospital. He's also the Executive Director of the Bloom Cardiovascular Institute right here in Chicago. Dr. McCarthy, I wanted to start today just so everybody understands your experience in this space of valves. Let's start with the cardiac procedures you've done over your career. Can you talk a little bit how many cardiac procedures and how your practice has evolved?
Yeah, it's not my first rodeo. I've done about 11,000 heart operations. I think I lost track counting them for a while. Probably about 5,000 or 6,000 are heart valve surgery. I haven't counted that one for a little while either, so I've seen it pretty much.
And in addition to valve procedures, I understand you've taken on a lot of different specialties over your career. Is that accurate?
Yeah, that's true. So early on when surgeons start, a lot of them do coronary bypass, especially 20, 30 years ago. The field was predominantly coronary artery bypass. So I did thousands of those, but also aortic aneurysms, and that's part of a bicuspid aorta valve operation. For many years when I was at the Cleveland Clinic, I did heart transplants. And so I did about 500 heart transplants. Left ventricular assist devices were just beginning. This atrial fibrillation surgery, the Maze operation, I was the second one to do that in the world behind Jim Cox. So I've done a lot of different things.
Well, on behalf of our community, I can't thank you enough for your dedication to this space, not only valves, but all the great procedures you've been working on and perfecting over the years. So thank you.
Thanks, Adam.
Yeah, and so the other question I had for you, and I'm sure a lot of patients are wondering this, you do these procedures every day. You're orchestrating a team, and what excites you about what you do every day you go to work?
All of those. So I still like to do the individual patients, to take care of them, and to do that. That's kind of still my daytime job. But before and then after surgery, I kind of run this team, the whole Cardiovascular Institute. And so we set our priorities, what are going to be the things that we work on next year. For instance, transcatheter valves, TAVR when that began, transcatheter mitrals and tricuspid now, that's a big focus for us. And so with the team, kind of gather all the information and then set the course.
Well, I also want to share something with you, a side story. Not too long ago, I was in an operating room. I was watching a procedure being done, and I looked over and there was a shelf of all these different boxes, and there I saw a McCarthy Ring, I think is what I saw. And
the
so
MC3.
And so
Yep.
You're also an inventor in the space.
I am. A lot of people don't know that. So a lot of people, there was the Carpentier ring and the Cosgrove ring and all that. I thought it just seemed maybe a little too egotistical. So the tricuspid ring, the MC3, the MC is for McCarthy. The 3 is because when we developed it, was the first 3-dimensional ring. It was the first one that has a shape change that actually was kind of in the 3 dimensions, the way it was supposed to be.
Wow, well.
But I kept it kind of quiet.
So keeping it quiet, are there other things that you've worked on in the valve space?
So other rings, like the IMR ring is with David Adams and Alain Carpentier, for instance, and then valve retractors, and then we've still got a few other ones that we're working on right now.
Wow. Well, as always, it's an honor to be with you, and thanks for what you're doing. Let's start with some of the questions, Dr. McCarthy.
Sure.
One of the first one comes in from Miraz. Miraz, I hope you're out there because this is coming for you, this answer from Dr. McCarthy. Miraz is curious to know about mitral valve disease causes. And Miraz writes, can you tell me what are the possible reasons for a mitral to be damaged in a young person?
Yeah, so there's 2 primary causes. In a young patient, it's almost always mitral valve prolapse, we call it. About 2% of the population are thought to have mitral valve prolapse, and it's called mitral regurgitation, that may have heard, or mitral insufficiency, the old word. And so what it means is that, I'll see if they can see this. The valve, every heartbeat should hit together like this, but it's pulled apart. One part goes right past the other. So in young people, that's the most common. So there's about 6 million people with some amount of leaky valve from mitral valve prolapse. The second leading cause is a heart attack. And so when the heart is damaged, it pulls the valve apart so that it doesn't hit together properly. And that is a different cause, not as much young people as they get a little older.
Great. Well, Maris, I hope that helped you. We're moving on to another topic that came, a lot of questions about this, Dr. McCarthy. It's about aortic valve disease, specifically aortic stenosis. And Shirley Lowry writes in, is there a link between diet and valve disease, as in calcification?
Yeah, surprisingly, not a huge link with that. It's not as if you take a lot of calcium or that you drink a lot of milk, your valve's going to get calcified. And so it's a combination of sometimes genetics. Some people are born with a bicuspid two-leaflet aortic valve, and they're prone to develop either stenosis or a leaky valve. And then the other is that just as people age, they get calcification. And so they may get it in their arteries to their heart, puts them at risk for a heart attack, or they may get it in the arteries that go to their brain, and that puts them at risk for a stroke. And some people get it on their aortic valve.
So Shirley has a follow-up question, right? We have this calcium building up, and she says, I have, Shirley Shirk, this is for you. I have aortic valve narrowing. It's at a 0.7. What does that mean?
It's bad, Shirley. You're going to need to see somebody about that. So the guidelines are such that when it gets to be 1.0 or less, that's called severe aortic stenosis. So Shirley is in the severe range. It's at the point where we start to think about whether someone would need an operation.
And just when we're thinking about, I loved how you were using your hands earlier.
Yeah.
Is this something?
So a normal valve ought to be about the size of a silver dollar, I tell patients, but when it's that narrow, it's about the size of a dime.
Wow.
And so it's really very narrow, and the heart squeezes and it pumps blood through that narrowing and puts a lot of work on the heart, which is how patients develop symptoms.
And just taking one step further, the constant work of the heart to get blood through that smaller opening, is that leading to the enlargement of the heart? And
the heart can get thick. We call it left ventricular hypertrophy. It's like any muscle, and it is pumping against this obstruction. And Schwarzenegger, you're always, lifting those weights. That muscle gets really thick under there. That's left ventricular hypertrophy. And the symptoms get worse when people in particular might maybe go upstairs or something. And so they're pumping against that obstruction, and their heart has to pump harder, and they just get really short of breath when they try to go upstairs.
Yeah, and so symptoms, we talked about risks. I think the ultimate risk here for Shirley is a question about aortic stenosis. Is it a fatal disease?
So untreated, it is a fatal disease. It's progressive. It never gets better over time. There's no medicines. I tell patients that are like Drano in a pill that would just dissolve away that calcium. The valve should be opening and closing like this, but instead gradually it's stuck. It doesn't open at all. And so it's a mechanical problem. They're going to need the valve replaced one way or the other.
Yeah, so Shirley, I hope you take all this information to heart, no pun intended, and get checked out sooner than later. And let's move on, Dr. McCarthy, to a subject that I know you have spent a tremendous amount of resource, which is understanding and helping patients from their mind, going through a very tough time in their life, helping them understand what to expect and what not to expect. And Steve, I want to thank you for this question. He asks, how much attention goes into understanding the patient's emotional background before and immediately after surgery?
So it varies by the patient, and for all of the patients, it's life-threatening, it's scary, it's open heart surgery for many of them, or it's some other new technique that is related. And so, for instance, we have a group that I hired when I started at Northwestern that do cardiac behavioral analysis and management. And I think you've actually interviewed some of them over the years. And so they're there to, number one, sort of direct us in what's the best way for patients that have a lot of anxiety. How can they diminish that? They have relaxation tapes. They have things like that. But then also the whole team approach. People feel better when they get the information. And so they come in. They don't know how risky is it. Many times it's not nearly as risky as they thought. They think they're going to have a huge amount of pain, and then they're happy to hear it isn't that painful for most patients. And so a lot of it is just reassurance, anticipating their questions, and then the whole team. And so we have nurses that will talk to them about what to expect after surgery and when they go home. So it's part of just sort of managing the patient's understanding of the disease.
Yeah, and we talked about, Steve asked about immediately after surgery. One of the questions that I've got for you is this idea, because I know for me as a patient, I struggled in that early part of my recovery.
Yep.
And then luckily, someone said to me, why aren't you in cardiac rehab?
Yep.
And that was a turning point for me in my recovery. I remember it clear as day.
Yep.
And can you talk maybe about cardiac rehab for the patients out here?
Sure. So cardiac rehab is sort of a structured exercise program. It is monitored, and for a lot of patients, it gets them out of the house pretty early. They have someone that is there that has been through it before. They're a coach, and so they maybe get them on the treadmill. And if the patient is left alone, they may not know how fast do they go, how long do they go, and so they have someone there that is going to help with that process. And the more that they do of it, the faster they recover. And so it really helped a lot for many patients. They love to go to cardiac rehab.
Yeah, no doubt for me, it completely turned around my entire recovery. So would you recommend that patients have a awareness to a cardiac rehab program before they even go into surgery?
It may help. They should research it. And so, and the other is that, for instance, us downtown at Northwestern, many of our patients come from far away, but they don't need rehab at Northwestern. And so many times in their area, the regional center will have a cardiac rehab program so that they don't have to travel for that. And they can just find somewhere that's convenient.
Fantastic. Let's keep the questions going. Moving on into the tricuspid valve, which we have not covered yet today. And I know this is another area of your expertise. Lucille asks, has there been any new procedures for tricuspid valve surgery besides the ring?
So there's a whole host of new therapies that we're working on. So for instance, transcatheter aorta valve replacement, TAVR, that began about 10 years ago and now is a phenomenal success. So the tricuspid valve's more complicated, it's trickier and all, but we're looking at a variety of new devices that can be used to treat the tricuspid valve without surgery. So they go up through a vein in the leg, get into the right atrium, and then there's various, like a clip, like mitral clip related that they can do. Sometimes they can just tighten it up, put a band around it, almost like a ring, like we place. And there's others where they kind of squeeze it together. And then there's an odd one where they just kind of float a balloon into the middle of it. And so the leaflets hit up against the balloon, and that decreases the amount of risk. So right now, those are experimental therapies, but there's a lot that is going on with it.
Yeah, when you talk about experimental therapies, it's very exciting regarding the tricuspid work that I believe your team is working on.
We are, several devices.
And it's experimental. Does that mean we're talking about kind of clinical trials? Are these feasibility studies? Are they?
Yeah, so far these are really early. There was a lot of focus on TAVR. Remember, TAVR went through phases when it was in randomized trials, and even before that, it was what we call a feasibility trial, where we were doing patients and they weren't randomized to conventional therapy. It was just patients who were really sick and maybe too sick to go through surgery. We were looking at that, and obviously all of that is FDA approved, and it goes through that whole process. And so, there's a lot of exciting developments coming through with tricuspid.
Fantastic. And so, moving on to another great question from Mark, and it's all about this question of many patients have heard of watchful waiting. I've been diagnosed 20 years ago. What's the right time? And Mark asks, I've been diagnosed with aortic stenosis and regurgitation. I've had 3 echoes, 2 stress echoes. I'm 57. I'm asymptomatic. And I'm just curious to know, is there a risk to waiting?
Yeah, so I just left a panel where we were talking about timing a surgery for patients who are asymptomatic. And actually later, first thing that what we observe is like 3 months after they get their valve operated on, patients that thought that they were asymptomatic, they say, I feel better. I just thought I was getting older and things, and I was kind of cutting back. And so they don't really realize that they're in fact symptomatic. So there's a variety of different things that we do for that group of patients to try to determine with an exercise echo and other exercise tests, and also just taking a really kind of careful history about it. Depends on the kind of heart valve there is in terms of, is there a risk? With aortic stenosis, there is what's called a risk of sudden cardiac death. Typically, though, that is preceded by episodes where patients get dizzy and they pass out, things like that. So, but The most important part about it is that the patients need to be watched, whether it's mitral regurgitation or aortic stenosis. They really need to be good about their follow-up. What worry us are patients that we say, you don't have symptoms now, but you need to come back and see us every 3 or 6 months, and we don't see them for a couple or 3 years, and that's a bad situation.
And so I'm curious to know, Dr. McCarthy, the progression of this disease is very peculiar. It seems like there's nothing rhythmic about the way that this disease, most forms of heart valve disease, can progress.
Yeah.
And I got to tell you, I was one of those patients who didn't get my echo done for 2 years, and then I went from moderate to severe.
Yep.
Is this something, and again, to the responsibility for all the patients, could you maybe speak a little bit about the progression of the disease and what's the patient responsibility in this process?
Sure. So the progression with aortic stenosis in particular is that we think of it as 0.1 per year. So you know that number I mentioned, 1.0, and Lucille, as I recall, was 0.7. So if you're 1.0 1 year, the next year most would be like 0.9, and the year after 0.8 and stuff. It's almost typically progressive, but there are some patients that kind of rapidly progress, and we worry about them. It might be 1.2, and we check them again a year later, and it's 0.8 or 0.9, and they've been more rapidly progressive. That may have been for you, Adam. I don't know specifically, but that group of patients in particular, even if they're asymptomatic, we start talking to them about doing an early intervention, because they could go from asymptomatic to being hospitalized with heart failure and needing really urgent surgery. And so that group, especially at a young age like 57, we may tend towards an early intervention.
Got it. Well, I hope that helped you, Mark. And now we're moving on to a very interesting question from Kay about surgeon disclosure. And she says, I have a great question. Seems like some surgeons are very direct and upfront about what portion of the surgery they would be doing versus their fellows.
Yep.
My surgeon was very direct and forthcoming. Others I talked to didn't even mention it. What is the standard disclosure for surgeons, if there is one?
Yeah. So most surgeons are pretty direct and straightforward about it, and patients ask me about it. I'll tell them that I don't open and close. I haven't done that in 25 years. And by way of disclosure, I shouldn't, because that's not something that I do all the time. It may be fellows, but these are not like medical students. These are not like a couple of months out. These are like 8 years out of training frequently. Or it may be physician assistants if people are in a private practice environment, that they may do that. Believe it or not, it really is pretty straightforward to just open and close the incision. It's not a big deal. But virtually all the time, the surgeon is there for the key portions, the central part of the operation. And many times we're there in the room too as the opening and closing is going on. We're just not actually doing it. So the amount of disclosure about it, it probably varies a little bit. To me, it's kind of like, it's such a minimal portion of it that we don't disclose the whole thing. But we don't start IVs. Some people are kind of surprised that I didn't pull the chest tubes or the pacing wires, and that's what the nurses do that at the bedside. And so people come in with a different level of expectations because they've never gone through heart surgery before, and they don't realize it's a big team. There's a lot of people that do all the different parts of it.
You just described me exactly. I was after the surgery, I had all these tubes and people were coming in and pulling things out. I was thinking, where's my doctor?
Where's my surgeon? Yeah, doesn't he have to do this? It looks like it must be important. But those of us that know, it's kind of like, no, that's easy.
Yeah. And so we're moving on to another question. A lot of patients in our community, they don't have just one valve problem. They might have 2 or even 3. Yeah. And Susan asks, how difficult is it to fix 2 irregular valves, a mitral and tricuspid, for example?
Well, so it varies. And so it is actually quite common that patients may have more than one valve involved, and it gets a little more complex with decision-making about timing a surgery. You may have moderate disease in both valves, neither is severe, but the patient has symptoms, and so you actually have to do the operation because neither are that severe, but cumulatively they're impacting the patient. It depends on, how complex. If you're there to do a mitral valve and you're adding a tricuspid, that may not be very complex at all. It may only add 15, 20 minutes. But if what you're adding is an aortic valve with a mitral valve and all, it depends on if you're repairing or replacing, the decision making can get more complex and it can add some risk potentially. And so if I'm doing that operation in someone who's 87, it's not the same as if they're 47. And so there's a lot of judgment that goes into this in terms of, well, you're prolonging the operation. Is it adding much? Is it, worth it to do that? Is it adding risk versus the benefit? So, it's kind of complex decision making. The operation itself is not frequently that much more complex, but
got it. I hope
takes a
that
while.
Yeah, I hope that helped you, Susan. And now we're moving on to aneurysms. And Jet Rep, this question and answer is for you. I've gotten a lot of your emails, and so thank you for being so persistent. Jet asks us, what is the average or normal size of an ascending aorta?
So it sort of depends on the age of the patient and the size of the patient, but it might be about 3.2 to 3.5 for the ascending aorta, and that's in centimeters. And so that's about 1.5 inches, 2 inches.
And then, if I understand this right, the concern here is the aneurysm can bulge. Or
yeah.
Can you talk about that for Jet? Because he also said, what other factors influence when the surgery is performed?
Yeah, so there's a fair number of factors that are influenced here. So number one is that if a patient has Marfan syndrome, Loeys Dietz, they have patients that form aneurysms, and usually there's a family history, and patients look very tall and kind of thin, like picture Abe Lincoln. There was a lot of thought that maybe Abe Lincoln had Marfan syndrome. So that group of patients, the wall of the aorta is very abnormal and very thin, and so we have a low threshold to replace it. We may replace it at 4.5 in some of the situations. There are others when it shows up and the patient may be 75 or 80, and it's just part of the degenerative process. And in that group, it may be 5.5 centimeters, and so we can safely wait a lot longer. And the one that we actually deal with day to day most often in this group is bicuspid aortic valve patients. And the bicuspid aortic valve patients, if we have to replace their valve or operate on their valve anyway, if it's 4.5 or greater, then for the most part, we replace the aorta.
Got it. And so we're wrapping up here, Dr. McCarthy. You got two questions. We can't leave a conversation with you without talking about atrial fibrillation. Obviously, you and your team are very dedicated to abnormal heart rhythms. And this question comes in from Jerry, who writes, Jerry says, after valve replacement, I developed AFib and was told I have to be on a blood thinner for life. Yet the last 4 doctors I've seen haven't seen or heard AFib. So is it possible for the AFib to go away?
Yes. So if a patient has never had atrial fib before, and then they go through any operation, like any coronary bypass operation, not even involving the valves, there's a lot of inflammation around the heart early after surgery, and it can trigger atrial fib. And so almost always it's day 2 or 3, but it could be a week or 2 later after surgery. And then we give the patient medication, frequently amiodarone as an example. And then usually at about 6 weeks, we taper or reduce it, and then it almost always goes away. And so for that group of patients, now everyone's a little different, and I don't know the specifics, but long-term, we don't typically give those patients any anticoagulation because the atrial fib was just related to inflammation and irritation of the heart, and that's what triggered it. And once you fix the valves or other issues, it generally doesn't come back.
Well, great news. I hope that helped you, Jerry. Last question I got to ask, it's not in the script, but we have a great opportunity here. You're talking to a lot of patients, and I know you're a patient. Yeah, you are definitely what I'd call a surgeon's patient. You understand the patient perspective better than many. And if you had one piece of advice for someone who's been diagnosed and told, hey, you need to go in for surgery, the time is now, what would be your recommendation to the patients in our community?
So do a little searching around. Your website is great in terms of information. They can find a lot of great surgeons. And it is out there, like, for instance, mitral valve surgery. Most heart surgeons only do 5 mitral valve operations a year. And so it's not something they do a lot. And it's like playing the piano. And the more that you do, the better that you get at it. And I guess the other would be in particular with mitral valve surgery, where getting a mechanical valve at a young age is really an impediment. They have to be on Coumadin the rest of their life, and so usually those are not emergency operations, and they have time to do a little researching and check it out. And this is one area of medicine where it's not like just treating a cold. You should do a little homework.
Yeah. Well, on that note, Dr. McCarthy, I want to thank you for your extraordinary support of our community. And I also have to give a shout out to Barbara Guerin and Megan Whalen, and of course, Jane Cruz and the whole team, and Trudy, who is there now too. I just want to thank you for all of your extraordinary support of what we're trying to do.
Thank you, Adam. Thanks for all that you do for the patients too.
All right. Take care.
Okay. Thank you.